Good morning. Dr. Williams, I'm the nursing care manager of the inpatient women's unit, Rochester coordinator. Very gonna change soon. Will Losey, who's over Clinton, will be over both, but I'm still going to change it. So the nursing care manager is up for this. Hello. So this patient ends up being a female. They were dispatched at 5:38. There's a chest pain. By 5:48, they arrived. Find a 70-year-old female sitting on her couch. She was oriented types 4. States she woke at 1 a.m. having some pain. It was heartburn and inflammation of 10-11. Started to increase in pain and now with a 8 out of she stated it felt like someone was sitting on her chest. History of COPD, smoker, an allergy, medication she referred to being on was hydromorphine. By 5:54, they got her vital signs, 142 over 99, 88, 19, 87 there. Got a 48 IV to the right forearm, administered saline and keep the vein open. By 5:55, they had a 12 lead. It showed ST elevation, lead 2, 3, ABF, and depression in G4, G5. By 6, the stimulant was called Union ER, and a 12 lead was transmitted. Vital signs were rechecked. You can see them there. Still complaining that her pain was 8 out of 10. By 6:01, they gave her 324 of aspirin. They gave her 0.4 of nitro spray. No changes. Still saying her pain was 8 out of 10. 6:02, second IV was obtained, 18 gauge. They started left AC, just left it saline locked. By 6:08, they have second 12 lead. There was no changes on that. I was also told they had problems getting it to Union, but they did end up getting the EKG out in the field. By 6:14, they got to Union Hospital. There's the EKG. Kind of questions some of what they reported on it, but see where the question a little different than what they reported. ED physician spoke with cardiology about the patient before EMS arrival to expedite transfer to the cath lab. That's because they got the ED on time. By 6:26, patient arrival to the cath lab procedure room. By 7 o'clock, she ended up getting a PTCA balloon catheter advanced to her target vessel. It inflated. They end up with a successful percutaneous coronary intervention, or PCI, with 2 drug-eluting stents to the obtuse marginal branch of her left circumflex artery, taking it from 100 stenosis to 0%. Noted the patient had 80 to 90% stenosis in the proximal to mid right coronary artery, which required intervention the following day. Our door to balloon time, 46 minutes. That was awesome. Patient was educated on the importance of being compliant with their medications, especially aspirin, Brilinta, Flutoprel, metoprolol, and statins. Counseled her on smoking cessation with a nicotine patch prescribed for discharge. Heart healthy diet education was provided. Just to follow up with the cardiologist in 1 to 2 weeks and referred to cardiac rehab. She was discharged 2 days after this. So there's our door to balloon. And as I was saying, our ACC accreditation site, it's always backwards. So I know we're in April, but it takes a while for their request to get things uploaded. So that's why we're always behind on getting you guys a score. So I would say by the next one, we should have February, March, maybe possibly April. But right now we're 100%. We look pretty good. Thank you for all you do.
Anybody have any questions for Brenda? Gonna move on to Union Hospital Clinton. Kale, are you on?
Good morning. Can you hear me, Barry?
All right, yep, we got you. I'll advance the slides for you. Just let me know.
Awesome. Thank you. I think I can do it from here. So Will's put together 2 cases. As always, we try to highlight 1 case from Park County EMS and then 1 case from Indiana EMS up here. So our first case here is a 58-year-old male, had some significant cardiac history. The EMS was dispatched out for this male in a vehicle off in a ditch and was dispatched for an actual possible stroke. EMS was notified at 9:30. They arrived on scene at 21:38, left the scene rural at 9:42, and then arrived at Terre Haute at 21:53. They were dispatched for a vehicle off in the ditch for this possible stroke. EMS couldn't find any entryway tires off into the ditch or anything. Patient eventually reported that he kind of felt hot, syncopal, and just kind of wound up in the ditch. Self-extricated, ambulatory at the scene. They throw him in the truck, report some chest pain, did obtain a 12 lead, transmitted that via e-bridge at 2144, showing a STEMI. Took him straight to Terre Haute after some aspirin, some oxygen, and some nitro. En route, he did become syncopal yet again. Heart rate was 48 on the monitor. Upon arrival at Terre Haute, at 21:55, cards was paged thanks to the e-bridge notification prior to their arrival. That EKG that they re-obtained in the ER showed that inferior STEMI. Within around an hour, patient arrives in the cath lab. Door to vessel, door to balloon was 65 minutes. Reperfusion in 81. That's awesome.
Good.
Will's attached some pictures here. I always love seeing this. That's kind of what it's all about, right? Time is tissue.
Very cool.
And then, yeah, he's put in here that the e-bridge notification, particularly for us up here in the sticks in Park and Vermilion County, that's huge. That allows cardiology to get that notification, get the cath lab en route, because this would have been an after hours case. So good stuff from us up here in the middle of nowhere. Next case. This was a 65-year-old man, again, with some significant cardiac history, smoker, esophageal cancer. EMS was called out to his resident for patient to have a possible stroke with chest pain that was radiating down his right arm. EMS was notified bright and early in the morning at 7:43. They arrived on scene at 0800, departed the scene at 8:19, and then they arrived here at 8:44. Again, make note of those extensive transport and scene times up here in the middle of nowhere. Per the run report, and again, I'll just make a synopsis of this. Upon arrival, patient was essentially non-compliant. The family had stated that he's normally alert and oriented. He wasn't complying with EMS assessment questions. Can you name yourself or what the date is or who the president is? Everything was met with an I don't know, kind of cantankerous, eventually kind of combative. They do wind up getting him into the ambulance where he's further more combative. They do manage to start an IV on him, attempt a VAN score for his marked left-sided weakness. He's trying to self-extricate him from the cot. They do wind up coercing him with a little taste of some Versed to get him to comply, and then they arrive at the emergency department here with about call the emergency department with about a 5-minute ETA. They arrive here at 8:49. A stroke alert's immediately called upon their arrival. Patient's taken to CT, 11 minutes, a little slow. He fails a Torbast, teleneuro's paged, and I don't know why there was such a delay getting teleneuro, maybe because the patient was cantankerous, I'm not certain. And then CT head and neck come back negative for any sort of LVO. With the patient's concern for chest pain, he wound up getting a CTA of his chest, showing a PE that kind of complicated his care. So cards was consulted and concurrently with neuro to see what needed to be done, any sort of antithrombotics versus anticoagulation or whatnot. And as with a lot of those complex cases requiring hands-on neuro up here, we don't keep them. So that patient was transferred out after quite a bit of boarding at about 4:20 here. Good assessments by EMS once again, just like the prior case. Again, good pre-notifications, which is important. Again, up here in the middle of nowhere, gives us that time to get the CT tables cleared and all hands on deck up here. And then very important for all stroke documentation is that very explicit notes by EMS and then by us in the emergency departments of that last known well. Like this morning or last night really doesn't cut it anymore. We need that 0907 on 49. It needs to be very specific. So, all right, that's it from us up here at Clinton. Thank you guys.
Thanks, Cale. Appreciate it. Next up is going to be Tina with the trauma.
That was fast. She's used to Beth being in them.
Yeah, usually Beth.
Morning.
Yeah.
Yeah, I know you'll all be disappointed. I only have one case for you today. But
Could be a good one.
cases. Yeah, he's gonna be, can you hear me?
Yeah, I think it was just somebody that wasn't muted.
Okay. Jackie's gonna talk about our new trauma activation criteria, well, it's updated. So this case, I usually show pictures last, but I wanted to show them first this time. Just because it kind of demonstrates how mechanism of injury is so important when you come up on a collision like this to think about potential injuries. This lady, 62-year-old female, is an MVA of a vehicle accident at 46 in Holman. It was last month. That was, I believe it was a Toyota Corolla, if I remember. And she was hit by a Nissan Frontier, going about 50, 60 miles an hour. The 911 call came in at 8:53, was dispatched at 8:53. They were en route 8:55, on the scene at 9:03, departed at 9:27, and at Union at 9:34. The call dispatch was 0, dispatched en route was 3 minutes. Arrival was 12, on scene 24 minutes. I'm sure that's right. Departure to arrival in ER 7 minutes, so the total 911 call to arrival at Union was 46 minutes. So EMS was dispatched to the scene for the 2-vehicle accident. It was struck by a truck on the driver's side, 12-inch intrusion, airbags deployed. Terrell Fire Department was on scene on arrival, trying to get the patient out. On arrival, the patient was alert. She was in the driver's seat with her seatbelt on. She was able to speak and could moan. I think there was side airbag deployment. Oh, I said that very sorry. Seat color was placed, limited assessment done to the entrapment. Extraction took about 26 minutes, 26 minutes. Patient's left leg was pinned by the plastic interior of the car that had come in, had to be released. They said to get her out, they finally took the board and had to like slide her up on it and get her out the side. Union ER was notified once the patient was extracted, placed on the cot and taken to the ambulance. She had a 2-inch laceration on her abdomen, bruising on the lower left abdomen, swelling, slight rigidity to the left lower abdomen. Her pelvis was stable, left hip deformed with crepitus, pain to touch, left lower leg extremity bruising, swelling, complained of lower back pain. Right lower extremity had an open wound medially with bruising and swelling. CMS ×4 pulses were thready. This time her blood pressure was 83/28, pulse 128, rest 24, and she was 94% of Romer. GCS at that time was 15. They started bilateral IVs, gave her warm IV fluids, monitored 12 lead, gave her some Zofran. She was complaining of severe back pain, but they had to wait until her blood pressure, they got it up a little bit, and then they gave her some fentanyl. They called an IHERN with trauma alert. Our pre-arrival note said MVA driver, side intrusion, left hip deformity, left hip, left thigh, and lower back pain, I think. Level 1 was activated at 9:30, and the trauma surgeon arrived at 9:36. At the time of the pre-arrival call, her blood pressure was 60/40. Heart rate was 134. The respiration should be 26, not 6. 98%. She was alert and oriented. So she met level 1 criteria because of her heart rate and her blood pressure. Excuse me. Patient arrival at 9:39. She was awake and alert on, she was actually yelling out in pain, kept saying my back's hurting, my back's hurting, and asking us to call her daughter. Finally, we were able to tell her, get her to understand her phone was broke in the wreck. So she was able to give us her phone number. So she was that alert. Pressure was 60/40, 134, 26 reps, 92% on non-rebreather. So before she arrived, Jackie had gotten the pictures of the wreck. And so we were looking for a binder, having a little trouble locating one, so we put a sheet on the cot because we figured she's probably gonna have some pelvic fractures. And then on assessment, of course, breath sounds, breathing through her chest wall, breast, back, her hips, deformities, bilateral thighs, and she had a puncture in her right palm. So because of her blood pressure was staying low, she had 2 rounds of MTP, she had TXA, gave her tetanus, started her on epi drip. She was on for a short time on a dopamine drip. But then when we started the dopamine, her pressure shot up and we stopped it and it dropped back down. We just we're having trouble getting that fine line to get a stable blood pressure. They put in a Foley catheter. It was bloody urine. We finally did find the pelvic binder and got that on. Those sheets, you guys will have to show me tricks with that because it was me and Dr. Pusha trying to put that on, and we're both kind of small people and she was a bigger woman. We just couldn't get it tight enough. So we finally found the binder and got it on. She was intubated because they were worried about her protecting her airway. Her FAST was negative. Right femoral C-line was put in. She had chest x-ray, pelvis, x-ray of the pelvis, CT of the head, CT of the C-spine, abdomen, pelvis, chest, and venous ABGs. She had a bunch of fractures. Pelvic x-ray shows that there were fractures lower pelvis laterally. So there was displaced fracture of the left acetabulum. When we put that binder on her, finally, I had my right hand up against her pelvis and was tightening that up, and you could just feel all those bones in her pelvis shift. It was kind of like when you're doing CPR and somebody's rib breaks and you can just feel them moving. That's what her whole pelvis felt like. Fractures of the anterior aspects, the right 5th, 6th, 7th rib, posterior aspects of the right 7th, 8th, and 9th, 10th, and 11th ribs. So she had lots of rib fractures. She had active bleeding in the spleen. There was acute complex fractures of the pelvis, fractures of the lower hemipelvis laterally with displacement, fractures of the iliac bone and the acetabular region. The posterior medial aspect of the acetabulum, an acute left hip fracture, hematoma in the subcutaneous soft tissues in the right hip. Pancreas, it said, was unremarkable, no hepatic laceration, no significant renal laceration. It's hard to get these films to look good on here, but I mean, if you look at the left side of her pelvis, you can just see that's kind of all collapsed. So she had some really significant fractures. Their diagnosis, of course, was MVA, restrained driver, hemorrhagic shock, and critical polytrauma. So she was transferred to IU Methodist at via Lifeline at 12:50. Total ER time was 3 hours and 11 minutes. And part of that delay, we try to get everybody out if we can in 120 minutes. But there was a little bit of a delay because she was so unstable when they called Methodist. They were like trying to stabilize her a little bit more so you can get CAT scan, try to get IR to see if they could do anything with her here. It took us quite a while to be able to get her stable enough, even to get her to CAT scan. Because we would have her on the drips, we'd be giving her blood pressure to go up to like 110. And we were like, okay, it's been that way 30 seconds, let's go. And her pressure would drop down to 50. It was just back and forth and back and forth. So finally, we were able to get her over there, got the scans done real quick and got back. And then interventional came over and they were looking at her, but by the time, while they were talking about what they were gonna do after the CAT scans, Lifeline was there. And we just felt like it was in the best interest for the patient, just get her up there as quick as we could. So this is the list that we got from IU when we asked for a follow-up. So this was all of her injuries. And what was it, 2 days later, Jackie, they said she was off her drips, off the pressor, she was off the vent, and they expected her to make a recovery, very long, slow recovery. I don't think she'd had any of the ortho surgeries at that time, had she? Yeah. And they had taken her from ER, I believe, to IR up there, and she had, was it 8 coils put in?
I don't remember. I thought it was on that list somewhere.
I didn't see it, but she had lots of coils put in because she had bleeding everywhere in her belly, so. It was just amazing that they did, acknowledge how hard everybody had to work to get her stabilized, to get her up there, so I think it was a great, job on fire department, EMS, and our trauma department to stabilize her and get her up there. The only thing that, maybe we could have done was put a pelvic binder on at the site, but I think with her being so critical, the quickest thing, or the best thing was to get her here as quick as possible, and they did, so, thanks for everybody.
Don't stay on the screen for a minute.
Oh, did a good job.
Yes. So I just want, you can go sit. I just want to talk about this. So Tina is way more Pollyanna than I am. I'm gonna be very real. Pre-hospital was fabulous, okay? We did not do well, okay? We did not do well. We got so focused on, so she was as wide as she was tall. Extrication sucked, okay? And it was a small car. It got hit by a full-size truck. It was a 46 in Holman. Both were going at a high rate of speed. Pre-hospital was fabulous. This is supposed to be up inside of there, okay? That's the acetabular. This is all crushed. She is as unstable as they come. You guys did, and I'm gonna talk about the patients here in a minute. It's not your job to make the activation in hospital, and we're gonna talk about that. I know what's happening. So pre-hospital was great. We did not do a very good job as far as, like we should have known where the pelvic binder was at. It had been moved. Somebody decided in their infinite wisdom to move it. You ever get on your truck and you're like, why is this piece of equipment not where it's been for 15 years? Because somebody thought, I'm gonna clean up and move it, right? It had been moved. It becomes chaos. You've been in our trauma rooms, and I mean chaos. And when they're this bad, it is utter chaos, right? Because I have trauma surgeons and I have ER docs and I have, at one point I come out and I ticked off a respiratory therapist because we had 2. We got her, and then we got a really sick patient that Lori's team flew in trauma too. And I said, if you don't belong in this hallway, get out. So we didn't do well controlling our scene. Okay, we have a scene 2. It just happens to be in the hospital. We didn't do really well communicating amongst all my providers. Methodist does something called auto accept, and I love it because it means I don't have to fight with them to take a patient. I have to fight with them to take this patient. Why on earth would Methodist debunk me in taking this patient? What do you think was going on? They can't die in the air, right? They're too unstable for the air team to take them. And she was as unstable as they come. She's not kidding. They get to the door, she crashed. They back up, they do more blood and stuff. Okay, they get to the door. And I bet they did that probably, what, 6 times, 8 times?
At least.
Just to get her to CT. Methodist says, I need IR to look at her. We can't take her until IR looks at her. All right, my IR guy says, yeah, I can look at her, but I gotta have CTs to know what I need to embolize. Okay, well, he needs them all, right? Head to toe. She's about this tall, head to toe. And in the middle of this, we get some family dynamics going on. So she has a son that actually watched the crash happen because he's at the Horizon Health Clinic out at 46 in Holman and is at the door waiting for her to pick him up when it happens. So the staff's going, what can I do? He's schizophrenic. He's 6'4" and 250 pounds. So somebody gets him to call us and he says, I'm so-and-so and I think my mom's there. Yes, your mom is here. Well, then somebody else is on the phone with his sister because she was coherent enough to say, call my daughter who's in Ohio, right? So the daughter's like, hey, by the way, my brother's schizophrenic and he could go off on you. It's pure innocent intention, but he's a big boy. Okay. So he's like, I'm gonna call an Uber. So now we got this family dynamics going on. Okay, don't call an Uber. And I'm looking at one of my officers and I'm like, can we send a cop after him? Yes, absolutely. You want lights and sirens? I said officer's discretion, because I didn't want to set him off, right? He did not go off on us. He was actually really good. The daughter's in Ohio going, am I coming to you? What am I doing? I don't know. So we finally get her stabilized enough to get her in the air. Over 3 hours is huge. That's way too long for a trauma, which leads me to why I'm actually standing up here to talk to you guys. Okay, this is our trauma activation criteria. Some of it we have to do. It's ruled by the American College of Surgeons. They say, here's the things that you absolutely have to call a trauma. The rest of it's proprietary, right? It's what we decide is a trauma for us. Level ones, we kind of hit it out of the park. We know that. The motorcycle wrecks, the big car wrecks, things like that. Level one is when we call the cavalry. So don't walk out of here saying, well, Jackie Martin said, I don't have to call trauma. Please tell us when you have those. So I'm a scanner listener for many reasons. I told these guys, my son's a police officer. I like to hear where he's at. I still have a heart in the fire department. Most people know that. So I kind of like to know where you're at, make sure you're safe, but it also gives me a heads up. And I can walk out to that charge nurse and go, I don't know if you're going to get it or not, but Medicaid's on a motorcycle versus car, or Transcare's on this in the county. Okay. And it gives us a heads up, right? Because you guys have been in our ER enough to know that it's Beirut on a good day, right? And so it gives my charge nurse a minute to say, okay, let me think about this. I can put this nurse here and this nurse here. Let me move this psych patient out, or let me move that ICU patient upstairs, and then I've got a trauma room. The more prepared we can be, the better it is for the patient and you guys, right? Because we can get you in and get you out. And you guys are absolutely phenomenal about helping. So once we really kind of hit it out of the park. So we made a few changes in level ones, and this gets everybody. This gets a trauma surgeon, blood bank. These guys have got help if they need it. X-rays there, respiratory's there. Our team usually comes out. The things we changed, and some of it we clarified. If a burn patient has an inhalation injury and or respiratory compromise, that's a level one, okay? So don't make it harder than it is. And our staff in the hospital are making it harder than it is. So here's what I want you to do. If you are getting pushback, I just want you to tell Diana, whether it's the patient's name, if you happen to know the nurse or the doctor's name, just tell her. And then she'll get a hold of us, and then we're going to take care of it internally, because our people are making this way too hard. If they have a burn and an inhalation injury, they have a respiratory compromise. Okay? I have amazing physicians that are going to look at me and go, hey, this patient has a respiratory compromise. If they have a penetrating injury to the head, neck, torso, groin, or extremities, if they put a nail in their finger, I don't care. I do care, but it's not an activated. But if they have a shank in the chest, okay, that's a level one. And I'm hearing things from the nurses like, but they were breathing fine. They had SATs of 99%. I got my butt in a ringer one time, and I will never do it again. Came from the prison and got shanked up here. He was 99%. He was talking to us and mouthing off. Old boy had a collapsed lung, and we dropped a chest tube and flew him to Indy. And I blew it off. Because you only do it once, right? If they have an amputated finger or toe, it happens, right? People get their fingers in saws, people get the toes in lawnmowers, you can live with that. What we're looking for a level one are the big things. If they whack their arm here, or if they get their leg under a tree, those are the things that we're going to call level one, because there's vascular issues. There's lots of things that are going to happen. Those are the things we want a heads up on. Still not your job to call it. It's our job to call it. Please don't make anybody think you have to call it. But the alerts, hey, I think this is a trauma activation. You'll hear that in the bubble and go, what do we have? Oh, the IHRN says, okay. Now let's talk about the level twos. So this is the cavalry. This is everybody. You get everybody and the brother on these. These are a modified version of that. So we don't call a trauma surgeon in. We don't call the blood bank in. We tell lab, we tell x-ray, we tell CT, we tell the docs, because it puts them to the front of the line for diagnostics. These people we want out our door in less than 120 minutes, 2 hours from the minute they roll in. That's a fast clicking clock when you're working on these patients. Like you look up and you're like, oh my God, I've been coding this guy for a half hour, or I've been, stabilizing for an hour. These, we actually have 6 hours to get out the door. Please don't tell your people that. We have 6 hours to get them out the door if we're going to transform, or 4 hours to get them upstairs if that's what we're going to do. So level 2 just means, hey, this is a trauma. They're not dying, but you still need to pay attention. So the things we changed here, some of it is clarification. It's not new. A motor vehicle with an ejection from the car. That's pretty significant, whether you were not wearing a seatbelt, you were an idiot, you threw it out of the ATV, whatever it is, if you're ejected, that has the potential to cause some significant injuries, right? It's based on the mechanism of injury. It's not based on the fact that that patient is awake and alert and oriented and talking to me and breathing fine. It's the fact that they could not be in about half an hour. If they are a rollover with injury, okay, they don't have to make a 180-degree circle to be a rollover. If the car is not on all four wheels, it's a rollover, okay? Our nurses are arguing, well, they didn't make a whole circle. Did you ask? Were you there? Did you see them roll and stop on the side, or did they just go like a cow? I'm a farm kid, okay? Is it an unstable pelvis? That lady had an unstable pelvis, right? But it was obvious, like obvious. When you guys pulled her out, I don't remember for sure. I think it might have been Jeremy Jones. I don't remember who the medic was. It was a seasoned medic. They knew when they looked at her that pelvis was unstable. You can't always see it. A lot of vessels, remember? Think back in anatomy, lots of blood vessels through there, tons of blood vessels through there, and she'd be bleeding out. If they have burns greater than 20%, I want you to stand there and do the Brillinines or the Palmer method? No, just give us a heads up. Hey, house fire, car fire, whatever. Because what's our biggest burner out here? What is it? You guys know? Smoker on oxygen. I think we had like 3 in 1 week. Okay, so if they have burns greater than 20%, we're going to call them a level 2. But if they have an inhalation injury, we're going to bump it up to a 1. Why? Because they're probably going to get intubated. They're going to get flown out. Espinosa is our friend, right? If they are at a high rate of speed with high energy dissipation, so that rapid deceleration. Okay, hit a tree, hit a parked car, hit a building. That's a rapid deceleration. Okay, suddenly stop. My husband always said it wasn't the fall that killed you, it was the sudden stop at the bottom, right? Okay. So my nurses, especially my baby nurses, are like, well, what do you define as a high rate of speed? No, if they're in a 30 and they're going 60, probably a high rate of speed. If they're on the interstate, you're probably looking at them. Okay. I'm gonna date myself here. When I was a basic EMT, Jeff Fox was very heavy into teaching it. And so he told us that every 10-mile-an-hour car travels, it's 1 foot of crush to your automobile, right? When you hit something head on. So if you got 2 cars, you got even more. Most cars don't have 5 or 6 feet in the front end of them, right? Most trucks really probably don't even have that, right? So that's judgment. So if you tell me high rate of speed, they're supposed to take you at your word. Pregnancy with significant mechanism. If they are pregnant and they are injured, now you had 2 patients, right? And we've had some big ones, right? Last 4th of July, I think, the very 38-week-ish something ran over by the car. We had one not too long ago that was a domestic that got purposely hit in the car and then he drug her out and drug her. If they're pregnant, they are a level 2 because now they are at even more risk. Adults that fall greater than 10 feet, that is a change. It used to say 20. You can do some significant damage off of a 10-foot ladder or a 10-foot roof, right? Depends on what you fall on. Look, if it's an adult that's over 10 feet, if it's a pediatric patient and it's twice their height. Here's the one that everybody misses, pre and in hospital. If an adult is carrying an infant and the adult falls, is that twice that infant's height? Sure it is. Sure it is. If a toddler falls off of a top bunk, is that twice their height? It sure is. They'll probably bounce and survive. I had one that did that one time, but they fell on carpet, right? He just grabbed his blanket and went back to sleep. Any considerable risk of injury if they're over 65, equal to or over 65. This is where the big change is coming. Again, is the list in here, Tina? So up to this point, this is the one that we held off on until the College of Surgeons forced us to do it. Up to this point, they had to be on an anticoagulant. I'll have Tina send this to, actually I'll have her send it to Barry, and then Barry can get it out to all your agencies.
He's got it.
You got it? Okay. Up until this point, they had to be on an anticoagulation with a head strike. Now I want you to think about it. Just tell us, and again, not your job to call it. And if you're getting pushback, please tell Diana or whomever your boss is, and then they can get it to us. So it's changed. So it's really anything that's going to thin the blood. And yes, aspirin is on this list. Sure. So if they are 65 or older and they have some type of a significant injury, okay, and they're on anything on this list, we're probably going to call it a level 2. If you don't know, you don't know. You tell us that. Patient, right? I don't know, I take the little white round pill. Patient says they're on whatever, blood thinners, anticoagulation, but they don't know what the name is. Our docs and our nurses are gonna make that decision. It is not your job. I promise you, it's not your job, although some of the nurses are telling you it is. It is not. Your job is to give us the warning, okay? And the earlier you can give us the warning, the better off. I love it when you guys call the charge nurse and say, hey, listen, we're on scene. It looks like it's gonna be a long extrication, especially those of you who go on the county. Looks like it's gonna be a long extrication, but this patient is in a significant injury, significant impact. That helps us. It helps us get people ready. If we can have the trauma surgeon here before, that's even better. Think about like Tree Guy or the butcher kid that came from Clinton or the 46 and Hallman lady. We were ready. We were ready because seconds count. Like she was dying. None of us thought she would make it in the air. That's why Methodist was a little hesitant. We really thought she was gonna die before she got in the air, but she didn't. Because you guys called, we had our team ready, the doctors were in the room, everybody was in place, and we did it. So I'm gonna have, this is gonna go out, I'll have Barry send it out to your bosses who can get it to you guys. I don't expect you to memorize it. If you screw up, it happens. When you give the IHERN, then we're gonna look at that and go, oh, hey, Dr. Milana, this patient takes Lovenox and she fell and whacked her head. Okay, that's a level 2. Any questions? Bradley,
Question.
it's okay.
I told you to stop.
Hey, these are legit questions, so. So this is internal for you guys, right? We still go by CDC field triage criteria?
Yes.
Okay.
Yes,
And that's still in our protocols to call trauma alert based off of that,
yes.
and then determines which level of trauma center we go
Right.
to based off.
You just happen to be fortunate enough that they're both a level 3 here.
Okay, so is shock index still a part of that?
For you
Is,
guys,
like the case study that you had for trauma?
so
Like,
we
the
don't
shock
use it
index alone would've
internally,
said that
we don't
need
use
call
it
for
inside.
Lifeline,
Right, and we had that discussion actually
Yes,
with the medic,
okay,
because where it was located, they could have easily just drove straight to Lifeline.
yeah, he was right at us.
Discussion, that lady was so unstable.
He said he
I'm
just did
sure they would have put her in, does that make sense?
Yeah.
Okay.
well, I also know that whenever Union and Regional done the level 1, level 3, level 2, it kind of muddied up the waters
It did.
about, are we supposed to transport to a level 1, or are we supposed to transport here to stabilize based off of shock index? Have you guys?
So
has that
it's
changed,
still,
or-
no, everything pre-hospital is still what it was. It's still medic's discretion. If you are at 3rd Street and 8th Avenue, well, first of all, we're both level 3s now, so it's even playing field.
Right,
Your closest level 1 is Indy. So if you're at 3rd and 8th Avenue and your patient has a wreck like that, yeah, that would be silly to drive to regional. If you're at 3rd and Davis, it would be silly to drive north, right? So it's still the medic's discretion. It's still your choice where you're gonna go, what you're gonna do. Both hospitals are equal, okay?
Mhm.
We probably have just a few more resources, but both hospitals are level 3 trauma centers and very capable of taking care of big, bad trauma patients. And we both have flight services in and out, but you've also got, and I used to push it really hard and then I heard they were gonna get rid of it, but now I heard they're not. C-Flight is your friend. If you, that's actually better for the patient unless you're at 3rd and 8th Avenue and it's gonna take them, 20 minutes to get from home and field to our ground pad.
but you give us this information, we're trying to think ahead as well. I mean, I've called for Lifeline and loaded them up on your old.
Yeah, ground pad is free game. If you land on our
I just told
roof,
you that.
Okay.
yeah,
You still-
Well, the 120 minutes to get to a level 1,
in the door,
right,
here, once they're in our door.
right, but what I'm saying is we get caught in a situation where based off of like shock index, are we supposed to come here to stabilize first, or do we fly them straight out? Because there has been times where Lifeline has landed, we've transported to them, and based off of their shock index, they took them from scene to regional. So they
Oh.
could stabilize them.
So at that
and
point,
then
though, it's off your
fly back out.
shoulders. That's at the flight crew's discretion. And Lori can speak more to that. I don't live in that world and it's been a long time since I've played in it. But you made the decision that you as the medic, you're like, listen, based off the mechanism and what I'm seeing right now, I feel like this patient, and honestly, the state's gonna back you because they don't like double transfers. So when you bring them to us and then we turn around, and transfer them to the level 1, the state's like, listen, that wasn't the best interest of the patient. What you would have done, C-Flight, and we did talk about it, and he's like, honestly, I didn't think about it. I got so wrapped up in keeping her stable during the extrication, because it was like a 26-minute extrication. And like I said, she was as wide as she was tall, and she was in that little car. and-
I was not,
But I know who the medic was, and yeah, so-
so
So you still follow that CDC guideline. You still do what you think is best for the patient. And then if the flight crew decides that they don't want to take them, that's on them.
that could exactly what could have happened. He could have drove him over there like, hey, we'll help you stabilize them or whatever.
Right.
You know, that kind of.
So based off of that case study that you had, was that pelvic ring stable? Because it looked like there was a
No.
lot of iliac and all that, and acetabulum, which is outside.
She
the
had
pelvis.
so much bleed, plus she had a splenic lac something, she had like a grade 5 splenic lac. So
Kidney and
everything from
spleen
here to
back,
here was
yeah.
bleeding. That's another place where I think you did a very good job. Like, I think our images really didn't paint the picture. Cause then when you got to their stuff,
I know.
that's from IU, just from being in the ER. Like she had thoracic fractures, she had rib fractures, these anterior 5 through 7, posterior 8 to 11. She had, active bleeding. She had perirenal hemorrhage, she had adrenal hemorrhage. She had, look, her mesenteric arteries were screwed up. She had,
Don't change anything you're doing. The only thing they want you to do is say, hey, by the way, this patient takes aspirin. That's on them then at that point in time. That's the only actually really.
So you guys are getting pushed back, and I want you to know, that's why I said, I don't want you to walk out here and go, hey, Jackie said we don't have to call this. That's not what I want. Because the sooner you can tell us, the more prepared we are. And Tina and Trent, that's what they do. They're giving education all the time to the docs, to the nurses. And we have baby nurses, we know that, just like you guys have baby medics, and we have to teach them. I know your patient looks stable right now, but 10 minutes from now, they're not gonna be. That's like a kid, right? Compensate, 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 crash. These guys do it too. I was surprised she was awake when she got to us after that long of an extrication. Yeah, and her health was not the greatest anyway. Her size was totally against her. She had the adipose was compressing on everything, which may be why we didn't see the bleeding. I don't know. Like she had that much adipose. And so that might have been what kept, like we did 2 rounds of massive, MTP stands for massive transfusion, which is like 6 units total. It's different components, but so she had 12 units of blood. We didn't have a lot of blood. And then we get this really critical sick patient admit in trauma too. And we're like, all right, we got to share our blood here. None of us expected her to be alive to the air, let alone still be alive today. So yeah, you don't have to make those decisions. We just want to be open with you. We want to be transparent with you. We are changing them. I will tell you, the docs aren't happy and the nurses aren't happy because they're like, great, now we're going to call these level 2s. It's a no harm, no foul. It's in your benefit to do it because now you're going to bump your patient to the front of the line for CT and X-ray and lab and all those things that you need to make that decision. But that didn't affect you guys, right? You're like, I just need a room and somebody to give a report to. Tag, you're in. And that's what we want. We don't want to change that because the relationships are fantastic. You guys stay and help us when they're like this. The medics stayed in the room, help do the sheet, help get her transferred. I don't want to lose that. And you guys know it. I say it all the time. My heart's in the fire department because of my husband. I will never change that, but I will support every one of you. I used to work at TransCare. A lot of people don't know that. A long time ago, but I used to work at TransCare. I come from the world of aid ambulance. Some of you don't even know what that means. So, exactly.
Shut up.
Indianapolis dispatch, and they became rural medical, and then they closed the door. Those are great questions. Jimmy?
No, Chambers.
I think it's across the board though, with the county and with the cities, that there are medics and agencies that are afraid to use the air services because they're gonna get yelled at. We need to educate newer EMTs, newer medics, that it's a resource that can be used and benefit the patient.
I have baby
But also,
doctors, don't
don't
want
be-
heart surgeons in the room because they're afraid they're gonna get yelled at. Nurses are afraid of new
I
docs.
agree.
But they're
I don't disagree with you, Jimmy. It's
But
a
Jimmy,
matter
we
of,
grew up in the days of Ron Leach and Eric Bennett when it was a part of our life, so.
And those younger guys.
Before I give the floor to Dr. Malama, does anybody have any other questions? So still call them, but it's not your responsibility to call what level, that's
And
ours.
there's absolutely nothing wrong with meeting that helicopter on the pad.
No,
Both
and if you-
us and Union.
Yeah. Think about it more. They want it. They want those. If you're on our ground pad, it's between you and the flight crew. Now, if you land on our roof, the rules are a little different. We are obligated to get eyes on the patient, so.
Well, and in our case, our helipad out there, if you just gotta give us a minute to get security to block down the gates so we can make sure you got a secure helipad, but if you need to hop with that patient on the chopper, then come on home.
They'll land and they landed in the highway in front of my house. I got to sit there and watch it.
Hey, everybody, Dr. Malama's got next. Just, I don't know. Hey, just to let you guys know, because Union Hospital and Union Hospital Clinton, we are chest pain accredited and stroke accredited, we are required to do training on STEMIs and strokes. annually. And so we've been doing that through A&R. And so Dr. Malama is going to do that today with STEMI, so we can talk about that here. Thank you. Hi, everybody. Good morning. So, if I go through there's only so many STEMI variants, right? You've got 3, 4, sometimes 5 or so that you'll see. It gets boring. So I threw in a couple other things. Yell these answers out as you go through them. It's all pattern recognition. So it's going to be, what do you think's going on? What should be the next treatment? All right. So that's easier. That way it makes it a little more interesting and kind of go from there. So you get a patient and that's their EKG. What do you think? What is it? Orthodox, fantastic. What else can we do besides shotgun? Mag. Great. Lots of mag. How quickly you want to give that mag? 2 grams, as fast as we could? Theoretically? No. I'll think that's fine. So what are side effects of mag? Like if I give mag, what happens to somebody who gets mag? Let's say I'll give you both a pre-eclamptic or an eclamptic patient and a torsades. Well, but yeah, sure, that's the other thing. What's the other thing? Things I care. I don't care if they burn a little bit. It is what it is. What happens if I give somebody too much mag, for example? See, this is important to know, right? Because let's say you're driving a pre-eclamptic or eclamptic patient and you start hanging 4 grams of mag, which I look for side effects that I should worry about.
Hypotension.
Yeah, good. What else? Awesome. Deep tendon reflexes, right? One of the things you should think about is if the person is becoming fairly significantly high in mag, right? You want to consider this is not a common thing. I don't think, I have no idea where my reflex hammer is from 15 years of med school from before. But what do I use a lot of times? The edge of my stethoscope, you whack them on the knee hard enough and that'll be your kind of reflexes. So if you're thinking, hey, they're, for lack of a better word, mag toxic, consider checking their reflexes. And then if that's the case, now this is a balance between a pre-eclamptic patient and mag toxicity, but you can always kind of look at that and slow that rate down as much.
That dude becomes so prolific and smooth muscle relaxation.
Good. All right, but yeah, torsades. And what do? We shock this, we defibrillate, or we cardiovert? Good, defibrillate, right? What's another name for torsades?
Oh shit.
That's great, yeah.
It's probably more polymorphic.
Good job, right? So because what is what is ventricular tachycardia? The monomorphic, right? That's it. So this is polymorphic, so it looks very different across the whole board. While ventricular tachycardia is monomorphic tachycardia. Great. All right. Any questions about this? Full pattern recognition, looking at stuff. So let's go with this one. I'm just gonna always go with my thing. You get a patient who. Let's see how I can give you the scenario without making it obvious. You get a 23-year-old female who just broke up with her significant other, and she's got a history of anxiety and depression. Huh? No. It's a good thought, but not.
I didn't hear what they said.
I didn't hear what your scenario was.
23-year-old female, history of anxiety and depression. She just broke up with her significant other. This is not common, right? But it's something you need to always think about and keep in the back of your head. I'll give you a hint. Look at AVR. If there's anybody online, you can unmute yourself and key in as well, if you'd like. Is there anything weird about AVR?
We've always been told not to look at AVR.
Why? How about lead 1? Anything weird in lead 1?
We'll be out with the training chief on special detail, so we'll have to later respond.
All right, who remembers TCA overdoses?
Oh.
Yes, this is a TCA overdose. On lead 1, you've got an RVR pattern. So when you look at it, one and somebody, you gotta put 2 and 2 together. If I make it easy and I go, hey, she overdosed. She overdosed, right? But if I give you an idea, she's just went through a breakup, she's got anxiety, depression, maybe you gotta start thinking, did she take something that could have hurt herself? What is TCA? Antidepressants. What is it? What does it truly do? What do you think it's inevitably gonna do to our body? What am I trying to get towards? Is it something blocker? How many things do we block in our body? What we block? There's a beta blocker, great, so it's not a beta blocker, I'll give you that. What else could we block?
Calcium,
Calcium, it's not a calcium channel blocker.
sodium.
There we go, it's a sodium channel blocker. So how do I treat this? Sodium bicarb. Push sodium bicarb, you will actually see this arrow. As this widens, this will actually widen and become more in terms of a widened QRS. If somebody said, now, how often are TCAs used anymore? Not that much, really, because of this. But there are still people who are out on it. So keep this in the back of your head. Somebody comes in and says, let's say they called you for an overdose attempt, or you look at their meds and you see, oh, you got a TCA there. Don't ask me which one was last year. I haven't looked at TCAs, God knows how long. So Google TCAs and then you'll find them out. All right. Any questions about this? Keep it moving. All righty. So 50-year-old guy with chest pain.
Yeah.
Like, right, like this is like, grandma will look at that and go, that doesn't look good. Right? What do they teach you? So what else should I recognize on this particular EKG the way I've done? Is there anything specific that I want you to just tease out a smidge more?
Check for right ventricular infarct.
Good, thank you. What else? And what does that mean? So let's say he does have an RV infarct. What should I do or not do?
Based on his blood pressure, we're gonna withhold nitrogen.
Great, right? So remember, we're RV, right? So your preload, your RV, kind of, it goes from your your RA to your RV, very preload dependent. You drop their pressure with nitro, get a way worse scenario. The other thing that you'll see here is lead 3 is greater than lead 2. So greater likelihood of a fairly significant ischemic event there. And then obviously you got your reciprocals in 1 in ABL. Anything else? All right, so this one is a 50-year-old guy who has shortness of breath and some chest pain over the past 24 hours or so. What do you see? Somewhere you're going, you got half that thing in there. So there's alternans. What's the first word? Explain to them what you see.
Yeah, QRS complex, well, the whole complex is one smaller, then one gets bigger, one smaller, one's bigger.
Good, right?
Is it cardiac tamponade?
Very good, right? So you see that? So our amplitude is varying between each QRS complex. So this is a pericardial effusion. It could be tamponade, right? It depends on the physiology. So if the person's hypotensive and looking like crap, they're probably tamponade. But if they're there and you just see this is electrical alternate. So in essence, what's happening is the heart is literally swinging in the cardiac sac back and forth during it. So as it gets closer to your cardiac leads, the amplitude goes up. As it gets farther away from your cardiac leads, the amplitude goes down. Is there anything you're going to do for this? What can we do? What's the first thing we should do? If let's say we assume tamponade, what's the easiest thing we can do? Sure. What else? It's even easier than that. I don't think pericardial centesis are easy per se. If you do great, fantastic. You stick the needles in. I've done like 3 in 10 years, give or take. What's an easier thing to do? Like the easiest thing, like somebody farts and they get this. Easy. Great. I'll take oxygen. What's an initial easy thing?
Tell your basic to start driving.
Position of comfort.
Sure. What else? Let's give them a pressure of 80/40.
Fluids.
Thank you. Right? Because why? What happens? Our pericardial sac is fibrous. Not a lot of budge. Now, what you also can have is a chronic pericardial effusion. Now, chronic pericardial effusions will grow that sac way longer, right? And sometimes they can get a liter in their pericardial sac. Acute effusions have not a lot of space. Which of our 4 ventricles, which one has the lowest pressure? RA, RV, LA, LV. right atrium, 4 to 8, give or take, millimeters of mercury. So all you need is a little bit more pressure, causing pressure on that RA to overburden that right atrium, that then leads to hypotension. Easiest way to fix that, fluids. All right, so you give fluids. Give fluids, dry fast. Any questions about electrical alternates? Fantastic. This is a 25-year-old male with some chest pain for the past day. Does everyone agree with that one? Right? Could this be anything else?
Epicarditis.
You pericarditis?
Yeah.
I'll take that consideration, right? The reason I make this person a young person, that everyone goes, oh, they're young, they can't have a heart attack. It's actually not the case anymore, right? Sadly, more and more, if you look at the data behind pediatric patients, statins earlier on in life. So for example, I trained in New York, I grew up in New York, our patient population tremendously varied. If you saw a 35-year-old West Indian come in with chest pain, they were having a heart attack, pretty much, because they just have such comorbidity, so many comorbidities. They're like at statins at early life. So if you see that, so don't shy away from the age just because and then think it's pericarditis. It's not a bad thought. I would just treat this as an MI for now until proven otherwise. But it's a step. All right, pattern recognition, pattern recognition. This one is, let's see. This one is a 35-year-old male who intentionally took extra meds to harm himself. What do you guys see? Sure, give me something more specific. What's abnormal about this EKG? No P waves?
The T wave.
T waves. What's abnormal about the T waves?
Pointy.
I will disagree with you just a little bit. Not to say you're wrong, but I will disagree with you a little bit. They're wide, not pointy, wide. Right? So they're more broad. So what else? What else?
Beta blocker overdose.
Why do you think it's a beta blocker overdose?
I can't tell what the speed is, but it looks slower. And it's taking extra time to re-energize the ventricles.
Sure. So 350, 100, 350, 300, 150, 100, 75, 65-ish, give or take, is a rate. Not horrendously slow. What else? What else? Let's do our basics of EKG. We see P waves. Great. We have a QRS complex. Narrow or wide? Fantastic. We see our T wave, wide or narrow? Wide. What about our intervals? Intervals. What are intervals? Give me some examples of intervals.
PR segment.
PR segment, QT. Anybody think anything? So where does our Q start? Where's the Q? Someone point. I'm gonna start here. You tell me where the Q starts.
Right there.
Right here? Fantastic. Where does the T end? The QT segment?
Where it meets the isoelectric line after the T wave.
The end of the T. So that is a QT segment on this particular patient. Is that long? Would we even add a pro? You're a pro professional. Make that a prolonged QT. Prolonged QT, right? Everything under the sun can cause a prolonged QT. This is just pattern recognition to look at and go, oh, that's a long QT. Correct? What can we give them? Non-Zofran, sure. If you look at the research, takes about 24 milligrams or more to cause QT prolongation, but this is probably not the person I'd give Zofran to because you're already at like 600 plus. What can we give them though?
Epi, atropine.
Sure. Epi, not so much. Atropine, maybe if they really become more bradycardic and they're hypotensive. Use a MAG, right? MAG will hopefully narrow that QT prolongation a little bit for you. It won't be a magic bullet sometimes, depends on what they've taken. But MAG probably 9 times out of 10 really won't cause a ton of problems with this. Okay?
Still like 2 grams for it.
Yep. All right. This scenario is a 72-year-old gentleman, fell at home. Family hasn't seen him for about 3 days, pooped and peed himself, his left hip is shortened and externally rotated.
Accelerated idiopathy.
Okay, so thinking about that scenario, why? What do you think brought us to this? What's the pathophysiology that we're actually seeing in anything like this? Rhabdo, why do you think rhabdo?
Because he's been laying there for 3 days.
Okay, take that a step further. Give me a little bit of the science behind that.
Kidneys are failing.
Yeah.
Mm-hmm. So what happens when our muscles, so like, let me back up for a second. In essence, if I were to change the scenario to, I'm a dialysis patient and I miss dialysis for 2 weeks, what do you guys think? Sure. What electrolyte am I most worried about? Potassium. So this is why I just want you gotta take things a step further when you see people who are down. So don't just focus on, hey, I broke my hip and there's nothing else there, right? Person's been down for a while. Where does most of your potassium sit in your body? Intracellular or extracellular? Intracellular. Intracellular. Most of your potassium is in your cells. So the reason I say this is as we sit for a long time, our muscles break down. Most of our muscles then leak out all the potassium that are sitting in there. Now we've got extracellular potassium. On top of that, we're having poor oral intake because we're laying on our floor for 3 days because we can't go anywhere. On top of that, we go into renal failure, so we keep kind of keeping hold of everything. This is hyperkalemia. Okay? This, if you squint, you just gotta squint a smidge, squint, is almost becoming a sine wave. So what should we give? Calcium. See that narrow. All right, so I give calcium until this narrow. Any questions? The hyperkalemia is a bitch because it mimics a lot of other things. Hyperkalemia can present with so many different things. And so when you look at it, you go, oh, that's looking at your ventricular rhythm, right? Think about hyperkalemia. Think about the scenario, what's going on, and then see what you can do. Again, 99% of the time, outside of what we used to get taught of stone heart associated with calcium for DIG toxicity, which has probably been disproven at this point. Calcium, kind of like magnesium, really isn't gonna hurt anybody if you gave a gram or two and they magically nothing changed. You did really minimal harm with a good chance of benefit behind it.
So what is your dose for calcium?
This ideally you may need 2 or 3 grams, but it's all dependent on if you've got a good line, right? The last thing you want is calcium. Calcium gluconate extravasation is less comparatively risky. Calcium chloride extravasation, a lot of muscle tissue necrosis you want to avoid. You got a great line, a good 18, sure, push it fairly quickly. You got a 22, right? You want to be careful with how you do it. But the better you can give it, it's usually 2 or 3 grams ideally will change this. All right, this one. What do you guys think about this? All right, I'm gonna give you this one just because, again, this is actually another TCA overdose. Yes, so this is another TCA overdose. And so the things to recognize here, this is a narrow or wide complex tachycardia. Wide, right? So as that sodium channel blockade continues to worsen, you get a bigger and more wide complex tachycardia that's associated with this. What do we give? Push the bicarb, you will literally see this narrow. And then you just keep pushing, I know, how many we have on a bus? 2, 3, so. Kind of the best you can do.
for that.
Right, exactly.
Right now,
On bike arm.
Yeah.
Just gonna back order.
Or just 1 ml per kilogram. Right?
Yeah.
And then just call from there to go for more.
What do you guys think? Push that thing. Who's that? There you go, AFib, easy peasy AFib, right? Nothing crazy there. If they come in there, their blood pressure's fine, their heart rate's like 115. They're just complaining of some chest pain. Maybe give them some aspirin. Do I need to do anything else with this? No. If they're not unstable and they're just talking to you, this is just simple AFib. Very good. What about this one?
Mission 42, transfer ambulance.
Sinus braiding with pollens.
Okay, I can take that. What else could it be?
Transfer ambulance, 3461, St. Mary's Road.
CP waves?
244, at Mary
Third
Dale
degree.
Highway, Short Fall.
What I was thinking.
Transfer ambulance, 3461, St. Mary's
My
Road.
eyesight suffers from TMB.
244, at
So
Mary
I
Dale Highway,
can't.
Short Fall.
Slow AFib,
Okay.
right? So AFib does not have to be just fast, does not have to be AFib with RVR. You can have slow AFib. So when in doubt, what should we do? If you look at it, you go, and all these thoughts were fairly valid, right? Third degree, AFib, second degree, what can I do? What's an easy thing to do when I'm looking at just my 12 lead for 10 seconds of an EKG? Doesn't give me as much data as I want. What should I do next? Right, there you go. Print a rhythm strip. Give yourself a rhythm strip that you can then look at and go, oh, I don't see marching out. I don't see distinct P waves. Oh, I see that there's P waves, but they're not congruent with every QRS complex, meaning it's third degree. So that's the best way to do it. If you see a 12 lead and it looks like this, stop for a second, print out a 3 or 4 page rhythm strip and give your sense an idea of what else is going on, okay? But this was slowly fit. Alrighty, what about this one? Okay, describe me, what makes it a winky buck?
He would march away.
They march away? And then what's that? Describe, be more specific, what do you mean by P waves march away?
Longer.
There we go, thank you, that's what I wanted to hear, right? So everyone sees that, so PR prolongs, drops. Okay, very, very, very classic. You don't see this often nowadays, so prolongs, drops. So there should be a QRS complex right here. There isn't. Okay. Any questions about this one? If they're stable, do we need to do anything? No. Right. This person may inevitably get a pacemaker, but that's really dependent on the cardiologist probably. All right. Let's make this one 25-year-old skinny guy. He's got some chest pain.
Inferior off the top.
Mm-hmm. Why do you think it's an inferior?
Elevation in 2-3 ABM.
Okay. What else could this be? Let's say, I'm gonna change the scenario for you. 25-year-old skinny guy has no chest pain, has nothing chest pain related at all, was feeling like he's having palpitations.
Got a pneumo, that's.
Sure, I'll take that. Won't show up as much on the EKG, but that's fair. What else could it be? I'll give you one of the words, benign.
Early ventricular repolarization,
There we go. Why do you think that's the case?
because there's upsloping on the ST segment elevation.
Good, right? So everyone sees what he's talking about? So yes, there is an ST segment elevation here, but this is convex, right, versus concave. And that QRS goes right into that going upwards. So it makes it substantially more likely to be benign early repolarization. So benign early repol, typically you'll see this kind of T wave that's peaked. It is fairly asymmetrical to some degree, meaning that if you look at this, this is a much more sharp slope comparatively to this more kind of gradual upslope, right? And then I'm trying to think what else, obviously tends to be more convex than concave. No harm in calling that a STEMI and then we looking at it like, oh, this looks like benign early repol, right? But at the end of the day, that's benign early repol. Any questions about that one?
Do nothing.
You can treat it, listen. Does anybody explode from getting aspirin besides the people who got aspirin allergy? No, nobody exploded from getting aspirin besides the people who got aspirin allergy. So these are other variants that you see. You'll see kind of this little notch typically, not always, right? But typically you'll see a little notching like this. But it can look like that and then it can kind of progress and not be there at all. Any questions about benign early report? This is a 56-year-old female with chest pain. Where?
Looks like B2, B3, B4.
Okay, is that anything in particular? Is this, should I be worried about this? I just got, I think I inverted T waves.
Could be early sign of infarct.
Why?
Because phase 1 of the infarct can cause flattened or inverted. T.
Sure. Is there a special kind of name to this?
A stable angina.
Close, no.
I don't know.
Starts with a W. So what's, if you think it's Wolff Parkinson, why? What am I missing? Right. Are we looking at a delta wave at all? No.
You're talking about Willens?
There we go, Wellens, right? So Wellens has two variants, and this is one of them. It's deeply inverted T waves in V, usually V2 through V4. And what it kind of precludes is, not precludes, what implies is a probably early LAD occlusion. All right, so if you see this now, most cardiologists will look at this and go, I'm not gonna take that to cat. Give it, what should we do? What can we do? We can do one of two things. Repeat the EKG in 10-15 minutes, right? Obviously, if your ride isn't that long, not your fault, we'll do that. But if you have the time, if you're coming from a more rural environment, repeat that EKG as you go along, cheap and free and easy to do, right? Knows that the leads are already stuck to them. Do the EKG again. Or, and then treat them as a STEMI. It's a STEMI equivalent, but some cardiologists will not call it off this. You can fight and try and get it. It's like elevation in AVO. You had a question?
Yeah, so Wellens is kind of skipped over in our community, but the way we were taught was it can be intermittent and it can be cause a high miss rate
Mhm.
to where these have more, it's usually anterior, it's a high miss rate, and they can have higher morbidity because it's missed.
Yeah, it's a proximal idea. It's gonna kill a lot of people.
So is it intermittent, like you get this and then a serial EKG 5 minutes later, it could be normal and then it goes back, or is it still progressive?
I'll be honest, I haven't seen that much frequently. I really haven't, but that's my history, right? So I can't tell you off that. I have seen it varied, but I haven't seen it be intermittent. Yeah, but again, that's my own experience. It doesn't mean that that's necessarily the case or not. Alrighty. So this is a 44-year-old homeless guy who it's January and he's found out in the bus stop.
The junctional?
Very cold outside.
The hypothermic,
Why is he hypothermic?
because it's cold outside.
I'm looking for the answer on the cold outside. What's this wave cold? Cold.
It's the J wave, but I don't remember how to actually find it. I just remember hypothermia and it being the J wave.
Starts with an O, everybody knows? Osborne waves. This is an Osborne wave. So if you see this and it's cold outside, or I don't know, homie lived in a meat freezer in a restaurant or something, I don't know, it's like, I'm trying to think like where else you should consider these things. Think about Osborne waves. So what does this imply? Take this a step further. What should I be worried about?
Be careful with them because you can send them in that fib.
Exactly, right? It's just myocardial irritation. So this can go into VFib and then they'll arrest. So gentle movements. This is one of the few people we gently move, right? Turn up the heat in the back of the bus while we're waiting to transport. All right. This is a 62-year-old lady who just got into the fitness craze and she wanted to do a Tough Mudder. Never done a Tough Mudder before. She just did her first Tough Mudder. She got out of there. She got her medal. She just
Oh, those are fun.
Hypertrophy. She got hypertrophy. Shoot.
T waves again.
So, what do you think? Hyperkalemia, why? Why do I make it a Tough Mudder?
Not drinking Gatorade.
Not drinking great, not drinking anything. But why do I make this a scenario of a tough mudder?
It's hard. Use a lot
It's hard, right? And I give you a scenario of somebody who doesn't work out frequently. This is like, they worked out, they're like, I'm gonna go do a tough mudder. I've never done a tough mudder.
It's hard, they're fun, but it's hard. You get stuck in the mud and you're pulling on those mud.
Sure.
Mm,
Sure.
yeah.
Right? So muscle, so this is rhabdo as well. So think about those people, if you read, it was like a article in one of the newspapers about 6-7 years ago. People were getting the cycling craze, right? They got home cycling machines. I got a Peloton. I love my Peloton. I don't never use it because I've never freaking have time. But they got on their Peloton. They're not fit people, and they go and they do an hour on the Peloton, and they go off and they go, my legs hurt so much. And then they start feeling crummy and they get hypertension. Same thing as somebody who's laying on the ground for 3 days is the same thing as somebody who goes out and does a tough mudder, who's not typically doing a lot of exercise.
So then the lactic acid.
It's hyperkalemia, so you get muscle breakdown and then you get release of your potassium, then you go into hyperkalemia. Yes, you have some lactic acidosis associated with it, and that makes you feel crummy, but that won't make that.
So this is exertional rep though, right?
Yep.
So you would expect this, how often do you expect to see this if you see a firefighter come in with bunker gear?
It can, yeah, but the thought process is a firefighter with bunker gear hopefully has some physical fitness, right? To do what they're doing, that this is less likely. Now, a probie who didn't really kind of prepare for firefighter school and is feeling like crap and it's July, I may see this. But, a healthier person, or at least somebody who's been fit tested to some degree, should hopefully not have
Get a volunteer, I turn a middle of nowhere.
There's a lot of faith in our condition. Just saying.
Yeah.
Alrighty. This is a 62-year-old female with some chest pressure.
They're building a Peloton in the firehouse.
What do you guys think?
Inferior.
Rita, what do you guys think? This is
How old?
62.
Lateral, low lateral, sure.
Interior lateral.
Okay, I'll take that. Right,
Right.
everyone sees, so what are we seeing? Where are we seeing our elevations?
One ABL.
One in ABL, right? So one ABL is definitely more than one. Depending on, if you guys ever heard of Amal Matu, really great EM cardiology guy, does some great cardiology stuff online. So if you ever get a chance, Amal Matu, AMAL and then MATTU. You'll watch 30 or 40 minutes of his lecture and go, oh my God, I know nothing about cardiology, despite having either been a paramedic or a physician or whatever it be. So he will blow your mind, and there's some he'll start talking to you about what AVL can sometimes look like and just minor changes in AVL that sometimes present early before you even get a lead one elevation. But here, yeah, you've got an anterior lateral with reciprocal changes. Again, like these are just pattern recognitions. The more you see it, the more you go, oh, STEMI. All right, let's move on. Let's keep going. Sometimes there's not a lot to teach about it. This one is a 68-year-old with chest pain.
Down after that,
No, it was until you said that.
It looks like inferior lateral.
lateral, low lateral.
What else do I see that's not normally we see here? In our inferior, like typically what's our inferior look like?
2-3 ABL.
Right, 2-3 AVF. While 2-3 AVF are somewhat elevated here, what else do I see here?
3 is less than the rest though.
That, sure. What else? What else is abnormal?
It's a long. ST.
What's weird about V2 through V4? Depression. So we usually see that on an inferior in V2 through V4.
Good, we just damn hard, you know? Well, especially when it was working last shift. Working when we had.
Talking, you're not muted.
Oh,
That would be the hungry boys.
More Bob.
This is a posterior. So, you got depressions, V2 through V4. Consider getting a posterior EKG. Those may flip. Typically, typically where I don't put this, because this is an abnormal EKG, it's not very common EKG that you see like this. If I think of a posterior semi, where do I consider? Usually I see ST depressions.
Interior.
But it typically will be V4 through V6.
Yeah.
Right? That's why I've given you a complex EKG. This is more than just a posterior. Right? But if you see these ST depressions, get a posterior EKG, take V4, V5, and V6, make them 7, 8, and 9, and then print your EKG out. Take a look. Right? Always good to have that. Again, same thing as doing a right-sided EKG, do a posterior EKG. Cheap and free, easy to do, not hard. All right? Let's keep it moving since it's 10:25. Good lord. All righty. This one. This one is the other, just to be out of, just in the interest of time, it's the other variant of Wellens.
Move it to.
This is Wellens. Yep. So you got that Wellens criteria, that Wellens one I showed you. There we go, sorry. This one, so that's a humpback deformity, right? That's one version that you'll typically see. And then there is this version, which kind of just looks like a little saddle. So the humpback, just think of it as a much more deeply inverted T wave, while this one's a little bit more saddle. They tend to actually sometimes be a little bit more angulated, so you'll see a little upslope, then down into the inverted T wave and up, and that's why it kind of looks like a saddle deformity. This is the other version of Wellens. This is a sweet 89-year-old guy who thinks he may have taken too much of his medication accidentally. He I just don't feel good.
You gotta ask questions.
Oh my God. So yes, Nick, we're almost at the end.
Shot.
Well, what do you think happened?
I think he's symptomatic of bradycardia.
What do you think we took extra of?
Beta blocker.
Right? Easy thing to look at, beta blocker overdose, symptomatic bradycardia. Let's say he's sitting there, he's Brady, he just doesn't feel good, but his pressure is like 120/7. Do I need to do anything? No. What's an easy thing to do, but you don't have to start?
What's that?
Put the pads on, right? Easy thing to do, but you don't have to start. Best thing to do is have your pads in place versus be like, oh crap, he's crashing on me and I'm like 5 minutes into the drive and he's already wearing his puffy coat and his other coat and his 7 shirts and his skin scales that he hasn't showered out of in like the past week and a half that flowed out everywhere as you took them off. Get those pads on early. And if you look at it, more and more data is really showing, especially in our generally more well-endowed patient population from McDonald's and other fantastic foods that we eat, that an AP position, right, an anterior posterior position with pad tend to do a little bit better comparatively to anterior lateral, all right? So I would say if you're gonna put pads on people more often than not, put them anterior posterior. And the other thing you can do now, don't take this as gospel, because then you're gonna come back and you're like, well, I got shocked because of Dr. Malamed. If needs be, right, if you ever need to, do you have the paddles at all, or is it just pads, right? So you don't have the paddles. If needs be, because I used to have some paddles in ours, you can take a towel or two, fold it, put it on top of that anterior lead, and press down with your hand, all right? Ideally, you shouldn't get shot. I'm not telling you to do this. Well, you could if you need to, and the reason I say do anterior posterior in that setting is if you push on the chest this way while the pad is on their back on the other side, it kind of creates a more sandwich. And really, it's just the
Let's try that one.
it's like 60 milliequivalents. It's not going to be that. It's not a lot.
That's not that much.
Not that much. Yeah.
Just a little jolt.
All right. This is a 34-year-old with generalized weakness. ETAC. Cardiovert or defibrillate? Cardiovert. He's talking to you, right? If he's not talking to you and you're doing CPR, what do we do? Fantastic. Thank you. That's it. Any questions? All right, guys. Thank you so much for your time. Sorry it took so long. Hopefully it was useful.
Thanks, Dr. Malamed. Hey guys, a couple things to remind everybody.
the EMS challenge that we're trying to put together for something different, something new, that is next month. Deadline to sign up is the 19th. We have 5 ALS teams and 2 BLS teams signed up so far. So we'll definitely gonna host it for sure. There's a paperwork up here with the QR code or a link where you can go out and sign up. Very simple to do. Vituity Group, Dr. Malone's group is providing plaques to first and second place to the winners. I had somebody tell me they might be able to provide lunch in between, so that'd be kind of fun, something different. And I believe Trauma said they were gonna do something for the winners also. So just to let y'all know, something new, something different. We just try and do it. It's in EMS week. It's on May 21st. Speaking of EMS week, Brian and the regional is gonna be hosting EMS week on May 22nd. The luncheon will be on May 22nd.
Yeah, and we've also got a very interesting guest speaker coming in on that Monday. It'll kick off EMS week at noon. We'll have a virtual and a live, but the more the merrier. It's a bring your own lunch kind of a deal, but this gentleman is a medic over at Marshall and is a motivational speaker. He talks about laughter and communication with patients and how much that improves patient outcomes. And it's supposed to be quite a dynamic presentation from what I understand. So we'll be doing that on Monday, the 20th at noon. Of course, the EMS competition more.
Yeah, the EMS competition is gonna be in the POB parking lot where we normally do EMS week here at Union, and it's gonna be set up an outside thing. I have a room set up in the Lansbond to sequester the teams in there. We're gonna do 9 o'clock in the morning. There'll be preliminaries. And then the top 2 for each, BLS and ALS, the top 2 will come back and compete in the afternoon for the title of.
Bragging rights, guys.
It'd be something different. Thought we might try something new, and we got some people that are wanting to do it. It's gonna be a lot of fun. There will not be audit review in June. None at all. I'm gonna be out of town, so we're just not gonna host one that month. We're gonna have 11 this year instead of 12. So, but just wanted to let you guys know that. So, any questions for us? Thanks, guys, for everything. Have a great day.